Thank you, Madam Chair. And thank all of you for coming over and for your service in this efforts. Ms. Strauss, I'll talk with you, start with you. Some of the ideas you've discussed would take us back to what I think of sometimes as before times, before the Affordable Care Act was passed. Things like the, lifetime limits on enrollees, or removing a requirement to cover what are called the 10 essential health benefits, basic things like maternity care, prescription drug coverage, mental health treatments. These are things that affect the vast majority of Americans, and I'm concerned that some of the changes could take our nation's medical debt problem that you've referred to and make it much worse. Right now, we have more than 20 million Americans reporting having some amount of medical debt that hangs over their head. Colorado, that's over 360,000 people. So have you actually modeled how reimposing lifetime limits and other similar changes would impact the current medical debt crisis?
Yeah, so we do have information out on just how quickly, as you saw the chart that Senator Hawley just put up here, you could see from the time the ACA hit, our costs increased much significantly faster than prior to the ACA. So when you look at things like that, what we did was we just pulled off the cap on what people can charge. We're seeing $32,000 monthly costs for drugs today, for cancer drugs. You're seeing people charging for imaging at a huge amount, where before there was some sort of control. I'll give you an example. I have my twins that were born with their neuromuscular disease, spent the first 3.5 months in the hospital in 2004. They each got a hospital bill for $400,000 for 1 month. We didn't even come close to our lifetime maximum. So the numbers that you're looking at didn't always feed into what that lifetime maximum was. I never ran across somebody who did not have coverage, and I did see very high cost claimants come through that system. So also with the Affordable Care Act, I'll just give you an example of my own personal. My family's on a grandmothered plan, so a pre-ACA plan. We have a $2,500 individual deductible, a $7,500 out-of-pocket maximum. For my family of 5 in 2026, our premiums are $1,221 a month. If I look at a marketplace plan today, that same equivalent plan that now takes my out-of-pocket maximum up to $8,200 is double at $2,440. We have a crisis due to the Affordable Care Act regulations, and what it did is exactly the opposite of what you wanted. It lined the pockets of all the middlemen and gave them their own ability to charge and to collect income on much higher numbers with no negotiating happening at all.
Well, certainly that would argue for more price transparency, which was my next question. I wanted to start with Dr. Fegan, that so many of the ideas floated here today are obviously worthy of our attention and discussion, but we're not going to have time in just the next few days to effectuate certain changes, especially as so many people are seeing their premiums skyrocket. One proposal that we pushed forward for future discussion is our Patients Deserve Price Tags Act with Senator Marshall, which really does look at how do you create transparency and give people, especially people that manage the health plans for a large number of employees, the data to really hold the market, create some market competition. So Dr. Fegan, you've seen firsthand the impact of the high costs on patients and impact their decisions regarding accessing care and prescription drug treatment. Do you believe it's more important for any future legislative work on health reform to also include some efforts to get price transparency into the operating norm?
I think that price transparency is important, but I think that people need to understand that healthcare does not behave as normal market forces, and that people don't have the capacity to shop as we imply, for some elective procedure, you can look and see if an MRI is cheaper here or cheaper there. But the majority of time, people are making serious health decisions. It's a time of a health crisis.
Sure, I'm not suggesting people go out and shop every time they go see a doctor.
Now, I think we should have tried.
No, hold on. I think that what I'm suggesting, especially with the large employers that actually are managing the healthcare for thousands of people, when they can see what one hospital is charging versus another for the same thing, they begin to use pressure to make that data available and use it in making decisions on which insurer they're going to use. I think that's how
Yes.
you begin to drive
Yeah, I
prices
think that's
down.
essential. I think, in Chicago, we have 7 medical schools, and no one knows what each one is charging. And, it results in people charging what the market will bear. Well, we don't know what Northwestern charges. Why don't we try this and see if that's what they're going to be able
Exactly
to get?
my
So I
point.
think that makes a difference.
Great, I appreciate that. And again, thank all three of you for being here. I think
Thank
I'm
you,
out of
Senator
time.
Hickenlooper.